Hello and welcome back. I'm Rahul Gosain, here as always with my brother and co-host Rohit Gosain on our podcast, The Oncology Brothers. As practicing community oncologists, we're not only seeing solid malignancies, but many of us are also seeing hematologic malignancies as well. Today, we're kicking off a new series, diving into challenging real-life cases where often the question is, what next? This initial discussion will focus on relapsed refractory diffuse large B-cell lymphoma, particularly on our bispecific antibodies that are available. When do you use one over the other? How do you manage side effects? Is there any role of MRD monitoring? We have a lot to cover, and for this, we're excited to have Dr. Carla Casulo from my home institution, Wilmot Cancer Center, and Dr. Tara Graff from Mission Cancer and Blood Center. Carla and Tara, welcome.
Carla, Tara, thanks so much for joining us. Before we get into the space of relapsed refractory DLBCL, it is important to talk about what is the current standard of care from first line standpoint. That is R-CHOP versus dose adjusted EPOC or polar R-CHOP, where we are still debating which is the right patient population. Should we just be using this for ABC type? And if the disease in fact has recurred, then it is extremely important one should tie in with tertiary care centers. That is because one needs transplant after chemotherapy versus CAR T, or even the initial aspect of bispecifics for monitoring for a CRS, ICANS. And then the choice also is Lonca-T or Tafelen. Bispecifics are being considered in combination in frontline, but at least for now, they're only approved in relapsed refractory settings. Focusing on our current standard of care treatment options, what we have here is a 73-year-old gentleman with stage 4 DLBCL, non-GCB IPI score of 4. Two lines of treatment have been administered. One, the polar R-CHOP with a partial response, and then on progression, there was RICE administered, and the discussion was about transplant, but the patient was refractory as a result. Based on the discussion with the tertiary care team, patient has not decided to go down the route of CAR T, but how are you picking which bispecific to go with?
Yeah, this is a complex case, and I think we see this quite a bit. One of the things that I would ask is why the patient's not a CAR T candidate,
Mhm.
recognizing that CAR T cell therapy is not always available for someone, and we still see an under referral pattern for
Right.
patients who might be eligible. But for a 73-year-old patient with chemo refractory, I think CAR T cell therapy is probably one of the best choices that we have. And there are
Indeed.
some CAR T cell therapies that can be administered safely in this patient. But in the case of someone who is seeking a next line bispecific antibody, it really depends on, I would say, two things. One, is the patient willing to undergo a prolonged therapy, indefinite duration, which would be epcoritamab? Or is the patient more interested in a time limited therapy, which would be glofitimab? Efficacy wise, they're quite comparable. They've never been compared head to head, so we don't have randomized trials that can tell us which one is more efficacious than the other. So we have to rely on cross trial comparison. They're largely similar. The main differences are in the mode of administration, which epcoritamab is subcutaneous and glofitimab is IV. There's a there's slightly more days of treatment and visits with epcoritamab. Epcoritamab is indefinite, and it depends on the person's sort of thinking about it. Some patients find comfort in indefinite therapy, knowing they've always got something in their system that could address the lymphoma. Whereas others want something finite. I want to move on from this. And that's also quite appropriate. The other consideration I'll make is that the steroid burden for epcoritamab is a lot higher. Patients are on dexamethasone for the first few doses, and it's not an insignificant amount of dexamethasone. I think that could also be a quality of life concern for patients that don't like to be on dexamethasone.
Absolutely. Carla, thank you so much for getting us started here. Just because someone is not a transplant candidate does not mean they're not CAR T candidate. And when we're comparing these two bispecific, Epcoritamab and glofitimab, they both are CD20 and CD3 bispecific antibodies. The response rate looks similar, but the side effect profile also looks very similar in these settings. And then one thing more to add, with Epcoritamab, you touched on this, more steroids, but with glofitimab, the lead-in of anti-CD20 plays a
Right.
big role as well. So just few things for us to keep in mind when we're referring these patients or thinking of what next.
Tara. With
Yeah.
regards to the lead-in obinutuzumab, which is given with glofitimab, in terms of your community partners, do you have these community partners administer that and then refer you to tertiary care center, or the obinutuzumab, glofitimab for the first cycle is being administered at your home institute and then they are referred out to the community?
So typically we just do all the step up dosing in the beginning and then send them out. Now, there's no reason why a patient couldn't get obinutuzumab the first week and then be referred for the
Mhm.
first dose of glofitimab on day 8. There's no reason we couldn't do that, but I think a lot of community oncologists just want to kind of have that
Certainly.
first cycle. And even like with glofitimab, we monitor a little closer even with that first cycle, that cycle 2 day 1 dose, because you can still see CRS
Indeed.
or cytokine release syndrome with that dose. So for glofit, I look at it as cycle 1 and then cycle 2 day 1 before I feel comfortable releasing back if that's what happens. Whereas the epcoritamab being weekly, you kind of have, do people have sometimes a later onset of CRS with the 4th dose? Yes, it can happen, but you really see that rise in CRS with the cycle 1 day 15 dose, which is that first 48 milligram dose. And then really that goes down after that. So
Makes sense.
a little bit different, but there's no reason the OB can't be done at the smaller site and then
Indeed.
referred in. But I think typically they're referred for that, second opinion for bispecific management. And that's just the way it's been.
One of the things that I've observed in some of the referrals is that the bispecific is like a triage system in some of our referral partners. If the patient lives within an hour of the center, then they feel safer giving the bispecific rather than sending them to us to do the ramp up and then sending them back. We've done it both ways, but I like that approach because it encourages a little safety net surrounding ability to safely
Mhm.
manage CRS. In fact, today I've been dealing with a patient who lives a good 3 hours from here who is experiencing CRS, and it's tough to be so far away and having to address this, and it's scary for other smaller hospitals if they don't have the infrastructure. But we have a phrase that we are now adding to our notes for anticipatory guidance so that there's a familiarity with how to manage the CRS and the extremely rare ICANS, which is almost not ever seen with this class of drugs. And I think that that's also helped to facilitate that communication across the board.
I would agree that we built order sets for 2 of the non-attached hospitals to help. They have oncology floors, but nurses might not be used to dealing with CRS. They're used to neutropenic fevers, right? So if someone's got a fever, everything is, a neutropenic fever. It can't possibly be CRS. And so we made order sets, and for our outpatients, medical bracelets. The ones for lymphoma are green, and for small cell, they're black. But that way, if they wind up at a hospital further away, they're
Absolutely.
traveling, something's going on, they at least have the CAR T medical alert, right? You have that bracelet that says what they're getting, phone number of who to call, and we can be in constant contact if they end up at an ER 3 hours away.
What I keep hearing is that education towards our patients, to the community partners, and ongoing communication for us to do this right.
Mhm.
All right, I think this is a good segue for our second patient, but also building up on the first patient as well. Tara, in the second patient, or that first patient with refractory disease, but in this particular patient, a 69-year-old woman with non-GCB diffuse large B-cell lymphoma. After first-line treatment, this patient did indeed get CAR T, but the disease was still refractory. The decision was to move forward with Epcoritamab. They've been on treatment for 4 months and now have complete response, which is close to 40% in the study.
Yep.
Can we use MRD assay here to consider stopping treatment? Also, role of IVIG in these patients with low IgG?
So that's a really good question. And that's something that we've been talking a lot, even at the summer congresses. It's come up on a number of steering committee meetings is, is every patient who's on epcoritamab really treat to progression, right? And on the flip side, is every patient that we take off of glofit, should they really come off? I don't think we really know the answer because the disease biology in all of us is so different, right?
Absolutely.
So I think you have to look at it. I don't know if I would do it at 4 months, but if I had a patient who achieved a CR fairly quickly, right? I think it'd be a conversation, especially if somebody all of a sudden starts getting increased infections, right? They're not clearing simple rhinovirus or they've got a persistent bronchitis. You look at a patient who's had R-CHOP, right? So they've had anti-CD20,
Yep.
they've then had CAR T, and now they're on a bispecific. So we've essentially exhausted not only their B cells, but their T cells too.
Right.
So that is a conversation that I will have. And I think that might be where MRD will play a role, is when you're trying to decide. We've seen from the studies, I should back up, from the 37-month follow-up, that those patients who achieved MRD by 3 months did very well long term. And that was specifically with epcoritamab. So I think it does play a role, and I would be comfortable. I have done this where I've had that discussion, but now you have to put in the conversation, okay, which assay are we going to use? 10 to the
Right.
minus fourth, 10 to the minus sixth, clonoSEQ, phase-seq.
Right.
We can't agree on any of those things. So do I think it plays a role? Yes, but what assay is going to be the best? I don't know. I think there's going to be variability there. So that, I think, remains to be seen. But yes, I would feel comfortable taking a patient off if they achieved a CR, early and we're maintaining that. I don't know if I'd stop right at 4 months. I probably would do at least 6. What's the right time point? Should it be 12? I think you have to go by the patient. Infections play a role for me. Now, the role of IVIG is important with patients with multiple myeloma. We're so used to checking quant IGs that it doesn't really get forgotten about. But I think in our non-Hodgkin's lymphoma patients, we don't always think about this, and we should be. It's very important that we're checking those IgG levels and that we are getting them the appropriate supplementation if they need it, because by this stage of the game, most of them probably do. So I think that needs to become, we think about prophylaxis for PCP and herpes virus and things like that. I think we also need to be thinking about the hypogammaglobulinemia that we see, especially after a patient's had CAR T and is now on a bispecific.
Carla, what's your practice like here, especially with IgG, that number? What are we monitoring? IgG less than 500, 400 is when you consider IVIG, or a role for prophylactic antibiotics that you utilize in these patients?
So it's fairly common after CAR T cell therapy, and the bispecific antibody definitely adds to that. My practice has been not so much kind of reflexive repletion of IVIG for a few reasons. One is that there's some studies to suggest that it may not be as advantageous to just treat the number, but rather if they have symptomatic hypogammaglobulinemia, I think that's probably more impactful for the patient. And some insurance companies don't provide that coverage if they don't have a documented infection. I've come across that quite frequently. But the hypogammaglobulinemia we typically manage with infusional IG every 3 months, occasionally more often, occasionally every 8 weeks. So it depends on the person and how much they're suffering from this. Many of the bispecific antibody trials during the COVID era saw a lot of treatment-related deaths due to COVID. Although they're not thought to be treatment-related, it's plausible that these infectious deaths can be attributed to the T cell depletion that these treatments are causing. So these are really important considerations, especially given that these drugs are being considered in earlier lines of therapy. So we may see a completely different side effect profile, like we did with the PI3 kinase inhibitors in lymphoma.
Indeed. Thanks for walking us through that, Carla. With regards to epcoritamab, the administration is subcutaneously. For first 3 cycle, it is to be administered weekly and then bi-weekly. Then after that is monthly. At least from community medical oncology standpoint, we are seeing these patients starting cycle 2 or cycle 3. Especially with the first cycle, we are worried about the tumor flares, CRS, and ICANS, and rightly so. These patients should be monitored in the tertiary care center. Tara, with regards to following these patients starting cycle 2 or cycle 3, any important clinical pearls from community oncology standpoint?
By the time they're on monthly treatment of epcoritamab or even the biweekly, their risk of CRS is really non-existent. It's really that first 4 weeks that we really worry about. And for the most part, we're really fortunate that the rates for CRS, at least for grade 1, grade 2, I mean, obviously the 51%, chance of CRS, but the majority of those are grade 1 events. So you're talking about fevers, and in a lot of cases, those patients are at home, right? They take their Tylenol, they take Dex if they're getting a pill in the pocket, which all of our patients do. So we're rarely even bringing those patients in. Now, I'm not saying they should be at a small center, but I'm saying that's how we typically manage. But if a person had a CRS event on cycle 1, day 22, then I may keep them a little bit longer for cycle 2. If they had their CRS event with their first full dose on cycle 1, day 15, they did fine on cycle 1, day 22, then I would feel comfortable releasing them back to their provider, assuming they had somebody who understood what to look for and there was a management plan in place. I would feel comfortable at that point releasing them back.
Carla, your thoughts here in terms of how common is CRS and how are you partnering with the community?
I agree. I think that the risk of CRS is greatest in the very beginning during the ramp up, cycle 1 particularly. And so primarily it's Tylenol and dexamethasone. When we first started using these bispecifics, it was more a question of let's ensure that we're not missing severe sepsis. Let's ensure we're not missing neutropenic fever. And I think in the beginning we did a lot of that. And then sort of now as we have greater familiarity with this, I think it's now recognize that these things can be very safely managed in the outpatient setting without needing to admit the patient. So we are following a similar practice of having patients managed outpatient, not bringing them in. Similarly, that's what we're seeing with our community partners.
Yeah, and again, this looks very different than what it was with CAR-T or bispecifics initially. These symptoms, CRS, are there, but majority of them are low grade. So again, in community, there's that safety net that things are indeed getting better. And Rohit, you touched on weekly and then bi-weekly regimen. This seems very similar to what we do for myeloma with anti-CD38 with like DARA. So again, there's that comfort. Before we switch to that last case, Tara, when you're using glofitimab, are you using this single agent? Are you using this with GemOx as STAR-GLO study, not FDA approved yet? What's your clinical practice?
I have used Glofi in a number of different scenarios. I've used it on trial where it's paired with different drugs, one of which we're going to talk about soon here, which is Lonca. I've used it single agent and then have also been part of the STAR-GLO trial. NCCN does recognize Glofit and Epco partnered with GemOx in the second line. I think that is being used more as a bridge to get to CAR-T, whether we even use all 3 drugs the whole time or initially do it and then drop it and use the bispecific. But I think it's with an end goal of getting to CAR-T at this point in time. I'm not saying that it won't be different in the future.
Absolutely.
But yeah, so I've used it in all spectrums. Every patient is a little bit different. When we do combine it with different ADCs or even with GemOx, the rates of CRS are quite lower. That initial debulking mitigates that risk. I think that's encouraging. Are these drugs having more utilization in the community at some point, right? I think it's interesting to see the way the drugs behave when they're partnered with different agents.
Perfect.
All right, moving along to our last case. Carla, I'll start off with you here, where we have an 82-year-old gentleman with stage 3 DLBCL, non-GCB, IPF4, mild renal disease, diabetes with travel restrictions, especially residing in a rural area where one has received 2 lines of treatment. First at diagnosis, R-CHOP, followed by POLA-BR. Just to key point here, Benda should not be combined with CAR-T. One should have about 6-month leeway because of the T cells there. So, Carla, residing in rural area where they can't come to tertiary care center even for the first month of monitoring of bispecifics, the choice of Lonca versus Tafalin, how are you deciding among the two, ma'am?
Well, they're very different also, but I would say this class of agents overall, while they haven't been compared head to head, are very similar in terms of response rates and rates of complete response. Someone who has travel restrictions, I think Tafalin is going to be challenging because of the number of infusions with the tafasitamab, and that may be problematic for this person. Lonca is certainly a consideration. One of the things with Lonca that has to be taken into account is the rates of pleural effusion, pericardial effusion, and then peripheral edema. Also, there's some photosensitivity, and given that we don't get much sun in Rochester, but when we do, it's really hot, and we've seen some severe photosensitivity in the summer with this drug, and so I think that's another consideration. But in this particular case, where travel restriction is sort of the main driver, quality of life and ability to feasibly get the treatment, I would probably select loncastuximab in this case.
Absolutely. I know we've gone through this rather fast, but Tara, any final words before we close in terms of what we should keep on our radar in community settings when it comes to relapsed refractory diffuse large B-cell lymphoma or considering these bispecific antibodies?
I think the take home here is the treatment landscape has changed significantly, and it's an awesome time for patients with so many options, but it's also a really difficult time for clinicians that aren't attending all the meetings, because we are attending the meetings and we still don't know exactly what to do. So I would really encourage community oncologists to reach out, right? To never be afraid to send an email, send a text and say, hey, what would you do? Right? It's not a matter of, hey,
Absolutely.
can you see my patient? Just phone a friend and be like, hey, I've got this person. This is what I'm thinking. Should I try this before that? How else do you navigate the situation? We do it with each other. I'm never afraid to ping a colleague and say, I'm kind of stuck on this. I want to do this, but they've got these things. Because when we think about Len, right, Revlimid's not a benign drug,
Yeah.
especially the dosage we use it at in this regimen. So it's hard to know all those little idiosyncrasies. So I think always reach out, and we have to help each other through this really exciting time in this disease.
Indeed,
Absolutely.
oncology is a team sport. Tying in your point, Carla, to the last case, with regards to tafelen, one has to keep in mind the renal disease with the
Yeah.
lenalidomide dosing, and also with Longitude, the use of dexamethasone to avoid some of these edemas and effusions.
Diabetes control, absolutely.
And then Tara, just to close off, I think if there's one thing that we can walk away with is ongoing communication, be it from our side or that partnering up with tertiary coordinate centers. Again, we've covered a lot here, but thank you so much for touching on some practical day in, day out things that we run into when we're seeing these relapsed refractory diffuse large B-cell lymphoma patients. Carla, Tara, thank you so much. In this episode of our new series with Dr. Carla Casulo from Wilmot Cancer Center and Dr. Tara Graff from Mission Cancer and Blood Center, we tackled relapsed refractory diffuse large B-cell lymphoma through real-life cases. Though we eagerly await approvals of these bispecifics in frontline settings, the current approval of Epcoritamab and glofitimab is in relapsed refractory space. Keeping patients' goals in mind, it is important for us to acknowledge that Epcoritamab is an ongoing subcutaneous regimen, whereas glofitimab is an IV treatment, and this requires a lead-in anti-CD20 antibody first.
During our discussion, we also had a chance to touch on roll-off MRD monitoring in these settings, given complete responses seen with some of these treatments. Although CRS is a common side effect, along with ICANS, majority of the cases are low grade. At the time of progression, our options are limited, including Longitude, tafelen, or clinical trials.
Let us know what you think of this new series and format, and if there are any particular scenarios you would like us to cover from your clinical practice, please reach out. Continue to follow us along for these discussions around the current treatment landscape and new approvals in the world of cancer. We are the Oncology Brothers.